Good evening, friends. Myself, Dr. Lakshmi Srikhande. I am the host for today's webinar on endometriosis and reproduction. It is my pleasure and privilege to welcome all the esteemed invited guests and our esteemed subject experts. Without wasting much time, I would like to introduce our chief guest, Dr. Rishikesh Pai. His biodata, friends, is very long, and I am very sure that each and everybody knows him across the country. But just to tell some personal things about Rishikesh Pai, he is a very humble, sincere worker. I know him since last 30 years when I was post-MD registrar in Breach Candy, and he had just started his IVF practice, and he used to come with all his paraphernalia, because that time we used to do the laparoscopic ovum pickup. So my honoraries and the teachers, they used to do laparoscopic egg pickup, and we used to give all the material to him. He used to see and say, yes, I have received the eggs. He used to take them, all those things, to his IVF lab. He used to do fertilization. So from that day, I have seen the growth of his Bloom IVF group. He has really worked very hard to have the chain of Bloom IVF group, and his passion for latest technique and technology also I am witnessing since last 30 years. When ICSI came, he went to learn ICSI. When embryoscope came, he went and learned embryoscope. And in his IVF chain, he has got all the latest gadgets, you name it, and he is having all the latest gadgets. So to formally introduce him, he is currently the medical director, Bloom IVF Group. He is the administrator for Foxy Manyata Initiative. He is director of corporate affairs of International Federation of Fertility Society. Friends, he is adjunct associate professor at Eastern Virginia Medical School, USA. He is postgraduate teacher in gynecology for DNB examinations, visiting professor OBGY, Manipal University, India. And his interest, of course, I told you, his passion is ART. He has been awarded with n number of awards. He has been also awarded with the prestigious FRCOG, and the most prestigious Lifetime Achievement Award is also in his credit. He has delivered many orations, and he has been invited as faculty across the world. He has edited 16 books and written more than 50 chapters. And apart from these awards, I know he is very passionate. Of course, he deserves. Rishikesh, I really wish that you should get Padma Vibhushan very soon. Looking at your work, contribution towards women health, I am sure very soon we will say Padma Vibhushan Dr. Rishikesh Pai. So waiting for that day to come. And I invite now Dr. Rishikesh Pai to say his chief guest address.
Thank you, Lakshmi. I'm really honored for being here today. Actually, I'm also a member of ISOPOP many years back. I remember I was in Patna when they got a conference, and I remember. So Dr. Lakshmi is going to be you will be the ICOG chair when I become the president, and all the academic activity I'm going to give it in her hand, because I personally believe that we must all integrate. So if at all, I am not yet decided what my slogan will be as Foxy president, but I thought I should have a slogan called unity in thought and action. We should all get united in thought and action, because only then, if we get united, only we can create an impact, because our country is 1.3 billion. Just imagine how many people we have got. So in order to, this is an argument I keep on having with Dr. Rishma or Dr. Nandita, my colleague. I said, can we really create an impact? She said, no, even if you change the life of one person, you will create impact. But yes, that is good for your heart. But in actuality, will you be able to create an impact for 1.3 billion? What can a Foxy president or a Foxy do to create that impact? And that is the question I am trying to answer within myself. Is there a way at the time when I get that small little time of 1 year as Foxy president, can I create such an impact that when I finish my presidency and I look back, will I be able to ask myself and get the answer that yes, I created impact in how our country looks for moves towards our health of especially women's health, because I am very focused. I don't want to do anything which is non-women's health, because there are too many organizations who are there to do other things. So how we can? So I am just requesting all of you. You are all my very good friends for many years. You come out with an answer how we can do change. And of course, Alpesh is my very good friend, Dr. Shanta Kumari, and hopefully the next president, whoever it is. We all should work together, because the change will come only when we unify. I'll just take one more minute, Lakshmi, that when I go to the ASRM, I always get very envious, because in the ASRM, American Society of Reproductive Medicine conference, it works like by clockwork. It doesn't depend on the human. They have reached a level of nirvana where everything works without who is the president of the organization. That is what we need to do. If we can reach that level where even if all of us are not there, it will run on its own. That is the way, and I hope that the future, there are a lot of dynamic people here who are there, and I hope in the future we can achieve that level of unity. This can happen only if we are unified. Of course, with unity, we lose individuality. See, it's a tussle. How can we be united? How can we come together? Then what will happen to my individuality? How will people know how good I am if I work together in a group? So this is a interaction, or this is a tussle in our mind which we have to come to terms with. And if we can come to terms with that tussle of trying to be individualized as well as united, then only we can achieve success. Thank you very much for calling me here. As far as the endometriosis is concerned, one request: always think about the ovary. So, just today there was a query, bilateral endometrioma, and she has got operated, but they should have done the freezing at the time. So there are 4 indications of ovarian tissue freezing at the time. So one of them is bilateral endometrioma. If it is there, it is better to also freeze the ovarian tissue at that point in time. So ovarian tissue freezing and oocyte freezing should be promoted through your forums of endometriosis. Thank you very much for calling me here.
Thank you so much, Rishikesh, for accepting my invitation and gracing this webinar of Vidarbha ISOPAP chapter. And it is very happy to note your grand vision as a FOXY president. I forgot to add that I have really seen your growth in the FOXY as well, when you were a foot soldier of FOXY 30 years back, and it is 30 years. You really contributed so much to the FOXY.
No, Lakshmi, my first FOXY was where my barring of the 1987 FOXY, but the 1989 FOXY was in Nagpur.
Yeah, I know that.
And that's where, in one of the small teeny-weeny halls where there were 10 people, I met a person called Dr. Pratap Kumar. He said, "Where are you from?" I said, "I'm from Mumbai." I said, "Where are you from?" He said, "I'm from Manipal." I said, "I've just come back from Australia. I've started." He said, "Are you doing vaginal pickup?" He said, "Yes." I said, "Yes." He said, "Can you come to Manipal and teach me how to do it?" And so I went to Manipal and I did the first vaginal pickup and taught him how to do vaginal pickup in 1990.
That is what I'm saying. I am witness to your personal, professional, and FOXY growth since last 30 years. So thank you so much, Rishikesh, for gracing the function. Now I move on to introducing our guest of honor. Our next guest of honor is Dr. Tushar Kar. As you can see, Tushar is always a very smiling, cool person. I used to become agitated because I was vice chairperson and he was chairperson ICOG, and he used to tell me, "Lakshmi, cool down. Lakshmi, this will be okay. Lakshmi, I will take care of the things." So, hats off to you, Tushar, and he really entrusted me with so many responsibilities. Thank you again, Tushar, for having so much faith in me as a vice chairperson ICOG. To formally introduce this great personality, he was chairperson ICOG, he was vice president FOXY, he was chairperson FOXY Oncology Committee, he is academic advisor to SCB Medical College, Cuttack, he was national corresponding editor of our Jogi, he was executive committee member to so many organizations, he organized state and national level conferences at his place, he is regularly invited as faculty to deliver guest lectures all across the India. He has contributed many chapters and published many articles. And as you can see, he is recipient of so many awards, and above all, he is a thorough gentleman and a great human being. Tushar, I invite you to share your words of wisdom. Unmute yourself, Tushar. Tushar, unmute.
Am I audible?
Yes,
Yeah.
audible, visible. Yes.
Okay. Thank you very much, Lakshmi, for nice introduction. But at the outset, I must thank Vidarbha chapter of ISOPAR, Srishali Lakshmi, and entire team for inviting me as one of the guest of honor. Really, this is thanks from my core of heart. But I remember this day, you have invited me once to Nagpur Society, maybe 1.5 years back, to give the oration, that memorial oration. And I remember that day. I feel that today I am in Nagpur.
Yes, you all are in Nagpur only, virtually.
Virtually Nagpur, correct. The second thing is that if you have correctly told that I always love to decentralize things. You can ask me, you witnessed me as the vice chairperson during our period, ICOG, we totally make it freedom, freestyle. Now all of you are there to work, and just I am to take the responsibility and just deliver the things in the proper way and in the modified and in the rather you can say accelerated way. Like similarly, being the HOD also, I deliver everything in that.
Yes, some network issues, I think.
We know that. Hello, Lasmi?
Yeah, again, yeah, visible. Yeah.
We know that, you see, it's a disease for last many centuries. But the only problem is that this disease is known as enigmatic disease. This is a disease of enigma. But why so? Because the pathogenesis, even the naming of the endometriosis is enigma. Pathogenesis, causation, diagnoses are not yet correctly known, and all these are hypothetical. But if you come to the exact, you see disease process now, there is a changing trend in the disease process. The incidence has increased. Why? Because of this certain true fact and again certain virtual fact. What is the virtual fact? But before going to the virtual fact, just only one sentence I will tell. True fact is that maybe we are thinking again hypothesis, maybe due to delayed marriage, delayed conception, and small family norm. But look at the virtual, because of the more use of laparoscopy, that is diagnostic histolaparoscopy for the evaluation of the infertility, perhaps that is one of the things over diagnosis of the endometriosis. Whenever you are putting a scope for an evaluation of infertility, perhaps that is another theory for the virtual. Maybe that has given the increase in infertility. All of us know that the correlation between infertility and endometriosis is relation like husband and wife. I'll say it is like just family. Whenever there is an endometriosis, obviously the infertility is following. And reverse way, whenever infertility is there, perhaps the endometriosis might be there it up to 30 to 40%. With this background, many veterans are there. So we'll be listening one by one, and Lakshmi has kept very nice that panel discussion which will enlighten all of us. And I wish this webinar will be one of the best forum perhaps to give the best lesson to all of us. Thanks, Lakshmi, and again, all the best for this webinar.
Thank you, Tushar. Thank you so much for accepting my invitation and gracing this webinar, and thank you for your kind words of wisdom. Now let us move on to our next great luminary, Dr. Sunita Tondulwattar. Sunita, I must say that when first I started knowing you, you had really an aura around you, and you are glamorous, and your personality was so great. But when I came closer to you, I realized you are such a soft-spoken person. You are so kind-hearted, you are compassionate, and you are so much spiritual that I developed a special bond for you. Friends, those who know Sunita, they must vouch with me that she is a very very, जो बोलते हैं कि दोस्तों की दोस्त यारों की यार, हमेशा दिल से कनेक्ट करती हैं वो सबको, वो है हमारी डॉक्टर सुनीता तांडुलवाडकर. She currently is the president IAGE and chief IVF consultant and endoscopist of Ruby Hall IVF Center, and you all have witnessed the great work which she did during her presidential year as IAG. She taught so many youngsters. She brought youngsters into the main fold of IAG. She reached out to the postgraduate students, which nobody thinks, and they need the endoscopy training because this is the need of the hour. If they come into practice, they have not seen, they have not learned. So Sunita, your vision, mission is commendable to reach out to all the youngsters and our postgraduate students. To formally introduce Dr. Sunita, she is currently Director, Solo Clinic, Center of Excellence in Fertility and Endoscopy. She is founder and medical advisor, Solo Stem Cell Research and Application Center. Here again, I just want to interrupt and tell friends, she is doing a great work in the field of stem cells, and I would, really looking forward to have her lecture on stem cells somewhere down the line in the near future. You must hear her story, what great work she is doing in this field. She is currently head of the Department of OBGY Ruby Hall Clinic, Pune. She is Chief Ruby Hall IVF and Endoscopy Center. And whenever I refer anyone to Pune and tell Sunita, please give my personal attention, that person definitely gives me feedback कि Sunita madam was fantastic. She really gave me personal touch and looked after me very well. Sunita, thanks for that. She is Chief Advisor, DPU, IVF and Endoscopy Center. She is Chairperson, Maharashtra Chapter, ISAR. Second VP ISAR, Founder Secretary Maharashtra ISAR, Vice President West Zone. She is associated with so many organizations. She has organized many conferences, friends. Her list of awards are too many, hence I am not individually mentioning any award. And she is a fantastic orator. You just have to listen to her. She is invited all over India and across the world to deliver lectures in the field of ART and endoscopy. Sunita, I welcome you here to say your words of wisdom as guest of honor.
Oh, Lakshmi, you made me speechless. You spoke with so much passion about everyone. That shows how large-hearted and how kind-hearted you are. Most importantly, Lakshmi, the energy what you have taken Vidarbha so much on a map of the country. It's equal to anything happening in Vidarbha or Maharashtra. Lakshmi has to be there. That's your passion, I suppose. And to teach, to take the people. See, even for this endometriosis, how you connected all experts from across here. कैसे नाम आते हैं तुम्हारे याद में? I really loved it. The topic of endometriosis is so important. And as Rishikesh rightly said, a decade down, when endometriosis will be discussed today, maybe 1 decade ago, we were discussing endometrioma, how to conserve, when to operate, when not to operate. Second important thing is if you are operating, how to conserve the ovarian tissue to the maximum. If you have a recurrence, whether to operate or go for ART. But decade down, everyone will say at the time of a surgery, ovarian tissue freezing is mandatory. It will become a protocol and everyone will speak. Another important thing which you will be discussing, most important, is endometriosis. First thing is no surgery is a better thing. So think 10 times in an adolescent age group. Think every patient as your family member and how you will be taking them ahead. Lakshmi, I'm not going to be in the way between the academics and you, but I love you, yaar. I love your passion. I love the way. And our dono ka aur ek thing hai, we became a Maharashtrian, but we both are Marwadi in Gujjus. Kanti, so much for your achar. Thank you so much. I know this is not the platform, but after I received your parcel, today I'm meeting you. So I must tell you, Kanti is not only a great academician, a great cook you have. You will see that in your panel. Thank you so much for being given this opportunity to me. And with Rishikesh, I'm just looking forward for your vibrant year. Yeah, I know you and Lakshmi combination, pura India do daloge. Pura. It will be so beautiful, so mesmerizing and vibrant.
But I
I'm
want all of you are there.
Yeah, we
यही
are there.
हम यही काम करते हैं ऋषिकेश. एंडो एआरटी ऑब्स्टेटिक स्टेम सेल पे कुछ तो करेंगे तुम्हारे ईयर में.
बहुत कुछ करना है.
But Sudhita, you are a great endoscopic surgeon. I mean, in so many workshops you came to Nagpur as a operating faculty.
I swear that
So many
conference
workshops you have
fantastic.
done. So
I know.
missing you in Nagpur.
With every state, Arun is here. With Arun also, I did Star Conference. So let us not discuss about my presidential year. Let's look forward for a fantastic lecture on a medical management and then the panel discussion.
Thank you so much, Sudhita. Thank you for gracing the occasion. And I thank you from bottom of my heart.
I
And
just 1 minute,
both the
1
rest
minute
our
of
Yes.
1 minute of Mahamrityunjay jap. Every
Yes.
one of you, those who are doing this, I just, if you don't mind, can I take you 1 minute of this just to make you understand the importance of a Mahamrityunjay japa? In Pune, two incidences. In Pune, we have Dr. Kundan Ingle got admitted. Everyone know Kundan. He's a chairperson of infertility committee. He's a diabetic. And the entire POGS, I made 9 p.m. sit only Mahamrityunjay Jap. Entire our POGS, and next day morning Kalyani Ingle gave me a call. Kundan is finding a miraculous difference. Now, second important thing is, just on last Tuesday, my pediatrician, neonatologist gave me a call saying one of the big builder, his kids, we have to severe imminent eclampsia. We delivered at 32+5. And he said, Sunita, I'm very sorry that baby is septicemia on ventilator. I don't think today I'm going to save that baby. Probably we are giving up now. I said, please don't give up. Don't use the word giving up for the baby. You don't know amount of efforts. I just want you to do one thing. What is the drug baby is on? He said, meropenem. I said, shift the baby on cholesterol. Baby was in a septicemia, DIC, ventilator, all gone. I said, I don't want, just go on a cholesterol and 5 minutes, wherever you are, just stop. I also stop. Bring that baby in front of your eyes and just we do Mahamrityunjay jap for that baby. I'm not giving up. You know what? Saturday morning, he gave me a call. Wherever you are, I want to come and meet you. He was crying. I said, what happened? You lost the baby? Don't worry. You worked hard. He said, no, I extubated the baby. Baby is out from DIC, baby is out, and I have extubated, and I just want to hug you personally. So there is a Mahamrityunjay jap. Please, all of you request together, believe in a prayer of powers. We are Indians, and we are fortunate that we have such a huge culture here, where japa, mantra, their powers every day. You all are witness. Those who are in my panel here, I can see on a screen. They know how I saved my mother from 2015, and till today she's everything fine. But my humble request to all: start with 1 minute of Mahamrityunjay jap for all COVID patients across the globe, for our healthcare workers, for police, for everyone. Just send this vibration. Please do that. We will achieve a lot. This last week, miracles, even the patient gave me call because after cesarean 2 days, once her BP is normal, we sent her home. She came to know that we did a Mahamrityunjay jap. Today morning, she came to meet me IVF department with the tears because she came to see the baby and she came to show the wound. So it's very important here. Okay, we spray some. Is the power which is working, not we. We are the mediators. We have to thank God who gave us more than what we deserve. Thank you so much.
So much.
Thank you.
I was
Thank you.
waiting for you to narrate that incident tell everyone the importance of Mahalakshmi Jap, because I believe in prayers and I believe whatever you said. And I will also urge everyone to follow what Sunita has just now told you to do it. Thank you so much, Sunita, for coming here. Thank you, Tushar. Thank you, Rishikesh. Now let's move on to our scientific session. And I would like to invite chairpersons for today's talk. First, I am introducing my very dear friend from Indore. Her name is Chandan Fafaria. Always smiling, full of energy, and she has solution for everything. Whenever I phone, she will say, "हाँ Lakshmi, सब अच्छा चल रहा है, कैसा चल रहा है?" And I must say, Chandan, you are the person who brought me to the MP state conference. Till that time, I was not knowing anything about MPOX. But she invited me and she keeps inviting me. We have fallen in love with each other. So great human being, a very humble, polite, soft-spoken, always smiling. She is currently senior gynecologist practicing for more than 35 years. She is past president of Indore OBGYN Society, past founder chapter secretary of IMS Indore branch. She has organized UFOXY and ISOPAP conferences at Indore. She has received prestigious SK Mukherjee National Award, and she was ex-president of MPOX. That duration was 3 years and she worked wonder. She has done so many conferences, CMEs, and she brought MPOX in the mainstream. And she was state coordinator of FOXY currently she is state coordinator of FOXY. Welcome Chandan for this webinar. Another great expert who is gracing this webinar today and she's chairing the session is Dr. Ritu Khanna, a very hard-working, humble, down-to-earth person, and she's a very, very thorough Foxian. I mean, core Foxian, works for Foxy, never says no to any work. She is currently director, Khanna Medical Center Fertility Clinic. She has taken training from Belgium. She is currently the chairperson elect of Foxy Food and Drug Medico Surgical Equipment Committee. And Ritu, you deserve it because you have worked very hard in Foxy to come to this level to be a chairperson elect. Friend, she has received many awards. She has published papers. Her field of interest is laparoscopy and histoscopy fertility enhancing surgeries, and her center is recognized by Foxy for infertility training. I welcome you, Ritu, for this webinar, and I hand over to the chairpersons for further proceedings. Chandan, unmute yourself. Chandan, you are muted.
Yeah. Thank you, Lakshmi. I cannot imagine your words and what you told me about me. Really, it is a more than 20 years friendship. She is very loving that I cannot imagine what I cannot express in my words about you. But really, you are very lovely friend like Kanti, and you are very synonymous for me always. And you are really, you are great words for me, and I cannot actually imagine that things. Good afternoon, everyone. I am really grateful and thanks to Dr. Lakshmi Srikhande for giving me this opportunity to chair this very prestigious session of ISOPAP. At present, I am working for the ISOPAP in Indore also.
Yes, yes.
It's my great pleasure to meet and see everyone on the screen, virtual meet. Dr. Rishikesh, great. Dr. Lakshmi has told us we will like to see Dr. Rishikesh as a Padma Vibhushan. We'll definitely best of wishes for you, Dr. Rishikesh. We'll like to see you like that. Dr. Lakshmi, Dr. Kanti, my good friend, Dr. Ritu, Dr. Pratik, Dr. Tushar, Dr. Sunita. I am so impressed of you. We met 1 year back, but Asha was organizing some conference, and really, seeing your spirituality and your job, top and month, really, I believe in that. And I'm doing this Gayatri month, but I will start with the Mahamrityunjay job. Definitely, I'm really, you are grateful to give these ideas to whole of our audience. Really, I'm really thankful to Sunita and all my friends. Now we are going to proceed in our today's deliberation. Everybody is waiting for that. And by Dr. Pratik Tambe on medical management of endometriosis. He's dynamic. He's great. Please share the screen for the Dr. Pratik.
Pratik, you can share your first slide is CVC. You share so that you want me to share your biodata? Yes.
Yes.
Here Pratik.
Very good. Yellow and green lines. Yeah. But there is no red line. Hello, Dr. Pratik Tambe. Am I audible? Hello?
Yes, Chandan, you are audible.
Okay. Dr. Pratik Tambe is very dynamic and great academician and he's consultant, ART consultant and gynec endoscopy surgeon. He's international diploma in advanced laparoscopy surgery from France. He's trained in assisted reproduction in Brazil and is trained in clinical embryology and ICSI London and Singapore. Great. He's the chairperson of EMOX Endocrinology Committee 2000 current 2022. He's a governing council member IFCOG 2122. He's the executive member, committee member in 2122 of ISAR. He's a managing, what not he's having. He's managing committee member and patron of Mumbai Afghani Society. He's a chairperson of Endocrinological Committee 17 to 19. He's the managing council member of IAG and AMC. He's a mentor of Emodious Youth Council. You are very particular about the youth. Really, I really appreciate you. He's a recipient of 15 marks, wonderful, and 7 Foxy prizes and awards. Foxy, Dr. Mehru Ansutia award is received. He's received Dr. Datta's Best Publication Award in 17. He has received Foxy Future Award and Foxy VRST Campaign Award in 19.
Ma'am, I think that should be enough. That should be.
I think it's enough.
That's enough. Thank you, ma'am.
I think nothing is left for others, Dr. Tushar, na? Sorry, Dr. Pratik. Nothing is left for others, and you are editor of 10 books. You are contributor to 50 chambers, 50 chapters, and more than invited faculty more than 600 events. Great, very great. Now I will not come in between you and Dr. Pratik. Please, Dr. Pratik, screen is yours now.
Thank you so much, ma'am. Thank you for that.
Tell something about Pratik that you can anytime phone in Pratik. I need this information, I need this literature, I need this PPT, I need this PDF. And tell you, friends, he never says no. He will say, yes, madam, I will do, I will find out, I will do it for you, I will email you. Pratik, up to you for your this helping nature, and his academic knowledge is really terrific. I am also eagerly waiting to hear, Pratik, your talk on medical management on endometriosis.
Thank you so much, ma'am. Thank you, Dr. Lakshmi Shrikhande, ma'am, for the kind invitation, and also to the Vidarbha ISPAP chapter. Respected dignitaries, guest of honor, chief guest, my pranams to all of you. And without further ado, I'm here to talk about medical management of endometriosis. The merit of all things lies in their difficulty. If you look at the evidence on endometriosis, how it has grown by leaps and bounds over the past couple of decades, all of you will agree that there is a lot of overwhelming evidence that's there, but often it tends to confuse ordinary mortals like you and I. So I've tried to structure this talk in a systematic fashion. First, we look at the current evidence from international bodies. We look at the FOXY protocols for practice. During Dr. Nandita Palshetkar's year, last year, when she was FOXY president, we did a special conclave called as Endometriosis Vision, and I'll be talking about that as well. We debate the medical management versus the surgical approach, which is always something which is there in most of the meta-analyses and review articles over the past couple of decades. And specifically, we focus on how effective medical management is, how long we can administer it, and whether it is the right choice for Indian women as well. We'll touch briefly on the role of counseling and fertility issues towards the end of the talk. Like I said, we have a huge amount of evidence. We have American College guidelines. There's the ESHRE guideline, which was published way back in September 2013. This is currently being updated, and anytime this year, we are expecting the update to the ESHRE guideline to be published. The This is the original article from Human Reproduction where that article was referred to. We have the Foxy GCPR, which was done when Dr. Alka Kriplani was the president of Foxy, and Dr. Ramni Devi, our immediate past. She's the current vice president of Foxy, was also one of the important people in that guideline. There's also a British journal article which looks at all the international and national guidelines, and this is a meta-analysis of all those guidelines. The NICE guideline was last published in September 2013. As you can see, there is no dearth of evidence. There is no dearth of articles to refer to. The problem is, how do you make sense out of them? And for that, it is necessary to divide each difficulty into as many parts as is feasible and necessary to resolve it. So this is the Foxy Endometriosis Vision Conclave, which we did last year. It was in February of 2019, in a different era when we actually used to have physical meetings. And in today's world with COVID-19 and social distancing, I don't think it's possible to get so many top level KOLs from all over the country, including senior eminent stalwarts, past presidents of Foxy, in one single place without this kind of social distancing. It's just a pipe dream in today's world. So we were very lucky to have all these wonderful people. You can see Tushar Kar there, Shanta Kumari is there, Dr. Nanda Palchetkar, of course, and Dr. Kuldeep Jain, who was the chair of the endometriosis committee, and myself, chair of the endocrinology committee. We were the co-conveners of this program. And you can see Dr. Rishikesh Pai there as well, along with a lot of other senior people. We divided ourselves into 4 groups: the diagnosis, medical management group, endometriosis associated fertility group, and the surgical management group. And we came up with simple practice based protocols which could be disseminated to Foxians all over the country. These are working pictures from that same meeting, and a whole raft of initiatives was discussed. We looked at all the current evidence as it stood, and we tried to make it simple, easy to understand, and disseminate it to everybody all over the country. We also had subsequent regional meetings. This is the one in Delhi. This was graced by Dr. Sunya Malik and Dr. Alka Kriplani. You can say Dr. Archana Verma is also there, Dr. Agini Agarwal, and Kaveri Banerjee. Very rarely she comes to meetings, but she was there in this program. We had one in Chennai as well in March. In Ahmedabad, you can see Dr. Manish Banker and Dr. Parul Kotadwal. I think Dr. Kanti Bansal is also there. She's here in today's program. So a lot of senior people gave their time and their energy, and they themselves, of course, had read up and they could contribute a lot. You can see Ritu Khanna here in the next program, which we had in Kolkata. Bhaskar Pal is also there. So out of clutter, we tried to find simplicity, and we distilled all the evidence and all the experience from these great eminent stalwarts into 2 little books called as Endometriosis Vision Protocols for Practice. These were released in Hyderabad at Dr. Shanta Kumari's conference in June of 2019 at the hands of our TIGO president, Dr. Purandre, and you can see Dr. Nandita Palchetkar also in the picture. So what are the recommendations that the entire group of experts made? We know that endometriosis usually is referred to as a disease which presents with a classic triad, which is dysmenorrhea, infertility, and dyspareunia. Unfortunately, this may not always be true. You may not always have a classic triad, and therefore, to diagnose the disease, it is ideally recommended to have a histopathological diagnosis. But today, we are moving away from traditional teaching. We are trying to push the space of laparoscopy a little further back into the background, where treatment takes center stage rather than achieving a tissue diagnosis before you actually treat patients. So let's come to the $1,000,000 question right away. Should we perform laparoscopy for primary diagnosis? Today, it's been thought that we need to have a paradigm shift in our approach. We need to have a presumptive diagnosis, and as many points as you can gather based on the history, clinical examination, the imaging studies, biomarkers which are available, and most importantly, the response to empirical medical therapy. If you have all of these corroborative evidences, then your diagnosis of endometriosis, which albeit is a presumptive diagnosis, is actually correct, and you need not necessarily have a diagnostic or an operative laparoscopy as a primary methodology, because ideally in today's world we feel that laparoscopy should be performed only once for any woman who's suffering from endometriosis. So primary medical management is now considered to be the first option rather than the surgical option of diagnostic laparoscopy with or without a tissue diagnosis with a biopsy. We are all aware of what the classic laparoscopic appearances are. I think I'm speaking to a very august audience and I don't need to explain to you what the laparoscopic appearances are. We are also aware of what the standard staging methodology is. There are more modern methods which have been described as far as especially fertility potential is concerned. There's something called as an endometriosis fertility index, but we'll not talk about that much today because we are mainly going to be focusing on the medical management. So, which non-invasive methods of diagnosis are currently being preferred? You have various different clinical examination findings, which have already been described in most of our textbooks. Transvaginal ultrasound is much more commonly available today as compared to 20, 30 years ago. Of course, in an adolescent or somebody who's unmarried, that may not be entirely suitable. But you have other imaging modalities like MRI, which are more and more being preferred because they have a very good sensitivity and specificity as far as endometriosis is concerned. And of course, the last stop, always the gold standard remains laparoscopy with a tissue biopsy. As far as CT and MRI is concerned, if you have lesions which are 1 centimeter or more in diameter, MRI will help you to diagnose these. They will also help you to distinguish endometriomas from dermoid cysts. And if you have deep infiltrating disease or if you have rectovaginal endometriosis, MRI is supposed to be the diagnostic imaging study that you should be resorting to. Also, if you have extra pelvic or what we call other ectopic sites of endometriosis like bladder or bowel or ureter, then MRI is supposed to be the diagnostic test that we should turn to. Of course, India being a country of huge diversity, not all patients may be able to afford an MRI, and in not every case would you resort to it. This is just to cement the place of these modern diagnostic modalities as part of the entire ongoing discussion. Now, how best to identify, diagnose, and treat medically the condition which we know as endometriosis. So to take us one step further, there are certain biomarkers which are available. And these biomarkers, traditionally, the discussion always starts with something called as CA125. CA125 is something which has been available for decades together. Unfortunately, it's a non-specific marker of peritoneal inflammation. It is not something which is specific to endometriosis. Of course, if you have endometrioma or if you have a stage 3, stage 4 disease, it's going to be rising off the charts, and there your index of suspicion anyway is high. Whether it is capable of detecting early stage 1 or stage 2 disease, that is where the proof of the pudding is. And unfortunately, it fails that test because CA125 does not have a 1:1 correlation with the early stages of endometriosis. What has now been found is that if you combine it with other markers which are listed out on this slide, CCR type 1 mRNA and MCP1, you get more than 90% sensitivity and more than 80% specificity for the diagnosis of endometriosis. Also, if you combine it with interleukin 8 and tumor necrosis factor alpha, again you have excellent sensitivity and specificity. Of course, this is something which is for the theory books. This is something which you are going to write in exams. I don't know of any lab in India today in 2020 which offers these as a panel. Maybe this will come to India in another 4 or 5 years' time. So just watch this space, and maybe this panel of markers, as we call it, is going to revolutionize our diagnostic approaches in the forthcoming years. And probably that is when we will finally be able to lay the entire controversy of laparoscopy or medical management to rest. As far as management of endometriosis in adolescents specifically is concerned, like we said, we like to avoid laparoscopy as a primary modality of diagnosis. Here we have a presumptive diagnosis of endometriosis, and we start medical management, which is typically with progestins. We have something called as Dynogest, which is now available to us as compared to the traditional combined oral contraceptives, which used to be given continuously or in a cyclical fashion. And we'll come to that in just a couple of minutes as to the place of Dynogest versus the traditional therapy. And if you have a response to this primary medical management within a period, say, of 6 months, which is a finite defined period, then your presumptive diagnosis is correct, and then you can continue this as long as the patient is comfortable up to a period of maybe up to 5 years, which has been seen to be safe, and you would try and postpone surgery as far as possible in these young adolescents until or unless they had severe pain, or they had endometrioma, or they had deep infiltrating stage 3, stage 4 disease. There are three conditions where typically medical management scores over surgical management, and that is in patients who are adolescents, secondly, patients who have chronic pelvic pain, and the third group of patients is patients who have recurrence, or those patients where you have operated and you want to prevent a recurrence from happening in the immediate future. As far as fertility is concerned, ASRM clearly has mentioned that fertility patients who are seeking treatment for fertility make very poor candidates for medical management, be it with Dynogest or with any other option, because all of these agents will prevent ovulation from happening, and therefore it is not recommended to prescribe medical management to women with endometriosis who are seeking fertility treatment. I hope that is very clear. When it comes to the medical options that we have, traditionally we have had two drugs which are available to us. The first is the combined oral contraceptive pill, and you can see here that though it is cheap, the effectiveness as far as pain relief is concerned is not very good, nor is it something which will continue over a period of time. Usually, after the first few months, there is a phenomenon of tachyphylaxis, and the effectiveness of pain control is much lower. Also, all of us are aware that there is some amount of risk of venous thromboembolism which occurs with combined oral contraceptives. It may not be significant for a short therapy of, say, 6 months or 1 year, but if you're going to give this in the long term for, say, 3, 4, 5 years, it definitely becomes an issue which is going to be troublesome, and sooner or later, the law of averages is going to catch up with you, and one of the patients may land up with venous thromboembolism and such disorders. The other option which we've had, and which all of us who are surgeons have very much favored for a very long time, is something called as GnRH analogs. And typically, we used to give this for about 3 cycles post-operatively after the patient had been operated on for endometriosis. Again, the effectiveness is excellent because there is desiccation of the entire raw peritoneal surfaces, and whatever micrometastases you may have or micronodules you may have of endometriosis, which you cannot address during the primary surgery, can definitely be taken care of with GnRH analogs. Unfortunately, you can't give them for longer than 3 to 6 cycles because they cause bone loss. And as we know, endometriosis is like hypertension. It's a disease which is going to stay with you in the long term. There is no permanent cure. All that you can do is try and limit it and hope that it does not progress to a higher stage. Therefore, long term therapy is the essence of all medical management. And unfortunately, that is where GnRH analogs will face that acid test. What do you have as an option that's available in? Then you have something called as Dynogest, which has recently come into the market, which is a progesterone which has 19 nortestosterone activity. The cost is reasonably low and the pain effectiveness is quite high. And we come to the issue of how effective Dynogest is. You can see here that when you compare 4 different symptoms, dyspareunia, diffuse pelvic pain, dysmenorrhea, and premenstrual pain, over a period of 20 to 24 weeks, which is approximately 5 to 6 months, the effectiveness of this drug is simply astounding. You can find that your visual analog scores and your pain scores will go down from a factor of 10 to as low as 1 or 2. And this effect persists beyond 6 months as well. It's not only restricted to the first 6 months, as I will show you in the subsequent slides. How do we follow up and monitor these patients? There's a simple flowchart that we have come up with, and this is part of the epoxy endometriosis vision conclave proceedings. It's there as part of the original document, and it's quite simple, straightforward, and easy to follow. Now, is this empirical treatment that we are advocating endorsed by any international guidelines? Are there good studies to back up this particular approach that we plan to take. Yes, there are guidelines from the World Endometriosis Society. They have recommended Dynogest as an empirical treatment option for women without laparoscopic confirmation, and of course as a suitable adjuvant therapy following endometriosis surgery. So in the good old days, when we used to perform an endometriosis surgery, we used to put the patient on 3 cycles of GnRH analogs. Today, what we would do is post-operatively, we would put up the patient on long-term Dynogest. How do we counsel these patients? Because as we said, this is a long-term therapy. It's a chronic disease, and sooner or later, it is going to impact psychologically both the patient as well as her caregivers. Now, this is a discussion by itself, and we had come up with a counseling kit for patients who are suffering from endometriosis and, of course, their caregivers. To briefly summarize what that counseling kit says, is that you need to sit down with the patient and her relatives, her parents, husband, whoever else is there as part of the caregivers and the immediate family, and explain to her that endometriosis is a chronic disease. There is no permanent cure, unfortunately, today. This requires multimodality care over the entire reproductive age span. So if she's diagnosed with endometriosis at say 22, 23, then she has at least another 20 years till she becomes menopausal. And as long as that period is continuing, she may still suffer a recurrence or a relapse at some point of time. It's important to keep in mind the end goal of the therapy. Now, today, the patient at 22, 23 may present to you with pain. Another 2, 3 years later, when she gets married, she may present to you with fertility issues. And therefore, at that point of time, you need to tailor make the treatment as per the approach that is required, as per whatever the treatment approach needs to be adjusted for what her complaints are. How long can we safely administer? If you look at the visual analog scores with long-term therapy, you'll find that up to 60 months of therapy is absolutely safe and fine. And these are studies from Japan. You'll be surprised to know that the first country where Dynogest was licensed was in Japan. And somehow Japan has a very high proportion of endometriosis sufferers. Maybe because a lot of their patients are from coastal areas, maybe they are rice eaters, or it's something very specific to the genetic makeup of women in that country. So some of the largest studies and most accurate studies regarding Dynogest in women come from Japan, and this is one such study from Japan where they gave it for up to 60 months, which is 5 years, to cut things short, and everything worked well without too many issues. And if you compare the effectiveness of Dynogest versus other modalities which are commonly used, like the GnRH analogs or the OC pills, you'll find that at 5 years, the recurrence is lowest with Dynogest. It's just 2%. And compare this with GnRH analogs, where it's as high as 50% because you can't give it for more than 3 to 6 cycles. We'll not talk much about OCs because OCs are not very effective as far as pain relief or prevention of progression of disease are concerned. I've taken the 2 best options here, and you can see very clearly that this is probably the best option that we have. So last part of the talk is to address the issue of whether we can use GnRH analogs. We've already talked about this. We've said that for the first 6 months, it's fine. Leuprolide acetate or gusarelin, whichever you use, is absolutely okay, but you can't use it for longer than 6 cycles. As far as fertility issues are concerned, this is something which Dr. Rishikesh Pai briefly touched upon before he left. I don't know if he's around right now, but it's important for us to counsel our patients, especially if they are in that childbearing age group. If they are going to get operated, please offer them the option of oocyte vitrification. It's important for us to create awareness amongst the general OBGYNs who may not be aware that this option is freely and easily available, and it's not too expensive today because of the economies of scale. The cost of oocyte freezing has come down significantly. If you need a brand ambassador, we have this lady who was there as the chief guest at AICOG Bangalore. Again, this picture seems like it's from a different era. It's just 1.5 years ago that we were in Bangalore enjoying the AICOG, and you can see Diana Hayden here. We also have a very fervent advocate of fertility preservation, our immediate past president, Dr. Nandita Palchetkar, And if you ever have any queries regarding this, please feel free to get in touch with anybody who practices fertility, and they'll be able to recommend the right treatment in the right short interval that you have available before the patient undergoes surgery. So, to conclude, ladies and gentlemen, endometriosis is an ever evolving field with new updated evidence. And probably once the new ESHRE guideline comes out, a lot of what I have said will either be vindicated or it will get updated and revised. So, watch this space. We know that it's associated with impaired ovarian reserve and poor oocyte quality. Any surgery that we perform, no matter how good a surgeon I may be, I may actually end up making things worse. Therefore, recommend oocyte cryopreservation prior to the surgery. Only perform surgery where it is absolutely and truly indicated, like say for a bad endometrioma, severe pain, stage 3, stage 4 disease. And the dictum today is that every woman should be operated maximum only once for endometriosis in her reproductive lifespan. Good counseling is essential, and the right treatment at the right time will probably help these women achieve a good quality of life. And a lot of what I have said probably sounds like common sense, because it is common sense. It's just evidence based common sense. And all of us feel that it's the most widely shared commodity in the world because we feel we are well supplied with it. Sadly, this may not always be true. Thank you so much for your patient hearing.
Thank you so much, Dr. Prateek. I think it was such an informative, lucid. I think it was a fantastic presentation. You really brought out the revolutionary change. It was just a scare. Any endometriosis means intervention. And today we are on to the medical management. So many options for us. And I think our patients and we, both of us can sit and relax. That agony of pain we were not able to control. And I think the most important enigma for this disease is the late diagnosis. By the time she comes to us, it's almost 6 to 7 years we've lost. And also the empirical treatment. And like we had a patient, adolescent girl, just complaining of pain. The only history she had was that at the time of her periods, she used to have painful, I mean, the stools and the urination, everything, and no other finding could be detected. We just put her on the empirical treatment and she responded perfectly. And the multi-modality, just like PCOS, I think it has
I think she is having some network
issues. Yeah.
Ritu, are you with me? Kanti, you can conclude. Unmute yourself.
Yeah, excellent presentation. I think such a huge topic and such a concise, all those PPTs. I am amazed at your presentation. Very well said. And what was more important now, diagnosis is extremely important. You covered everything about it, and generally you had a good overlay of the subject. And thank you so much for this. I think all our delegates are extremely enlightened by your talk. Yeah.
Thank you so much, ma'am. It's a privilege to actually have Shabashki from you. You are known to be the endometriosis chairperson for Boxy.
Thank you so much.
Thank you, Prateek. Thank you so much for giving that lucid and informative talk on medical management of endometriosis. Friends, now let us move towards the panel discussion. It's a unique panel discussion. It's a combination of reverse panel plus case-based discussion. So I'm sure all the participants will definitely enjoy and they will have some take-home messages after this panel is over. To moderate this panel discussion, I invite none other than Dr. Kanti Bansal. As Prateek has already said, she was heading the endometriosis committee of FOXY, and I really don't know how many publications she has got on endometriosis. And as you can see, she's currently the editor of European Journal of Endometriosis. And I think it's her passion to spread awareness and update on endometriosis. To formally introduce Dr. Kanti, she is Director, Safal Fertility Foundation. She is running 8 IVF centers across India. She has distinction of producing first IVF baby of Ahmedabad, distinction of producing first single mother of India. She has been awarded with RCOG Distinguished Service Medal for Development of Women's Healthcare. And as I already told the audience, she has published 12 books on infertility. She is peer reviewer for Jogi and other journals. And she is holding so many posts in various other organizations. Above all, friends, she is young at heart, humble, polite, always willing to help, and she always nurtures the youngsters as far as their academics is concerned. If they want to come out with the publications, if they want to present any paper, Kanti is always there to help each and everyone. I welcome you, Kanti, for this panel discussion. Paresh, what to say about Paresh? Paresh comes from a very small place that near Nagpur, that is Yavatmal. He was past president of Yavatmal OBGYN Society and he is currently running the Yavatmal Test Tube Baby Center. Along with it, he is a great endoscopic surgeon as well. He was organizing chairperson for masterclass and he is currently Yavatmal coordinator of our Vidarbha ISOPUB. But I must say that, friends, his positive approach to life is contagious. He is always positive. Whenever I have any problem, I phone in Paresh, कैसा होगा? Madam, सब अच्छा होगा. आप ऐसा करो, आप ऐसा करो. Paresh, hats off to you. Keep your positivity. Bless you. The next panelist is Dr. Arun Barua. Arun, we met, I think, some 30 years back in some Foxy conferences. He is my Foxy friend. And I used to wonder, who is this such a silent man who is always working for Foxy, never aspiring for any post, never having any expectation from anybody. And friends, he is currently placed at a rural place around 400 kilometers from Guwahati. And his commitment and dedication to Foxy is commendable because he had to catch flight from there to Guwahati, then Guwahati to some other place, and likewise he had to go back. So he used to spend 2 days in just commuting. So Arun, hats off, you are a Foxyan at heart. And currently he is consultant gynecologist at Sampriti Hospital. He has hold many positions. Friends, he has brought East to the map of Foxy. He has guided so many Foxyans and so many members from the Northeast to come into the Foxy fold. He was the organizing secretary of AICOG 2010, which was in Guwahati, and I have very good memories of that conference, Arun. It was a very, very successful conference. He has published 7 chapters in various textbooks, and he is a postgraduate teacher and he has many publications, regularly invited, and he never says no. He travels, he takes so much trouble to travel, but now he must be more happy that Corona is a blessing in disguise. So I welcome you, Arun, for this panel discussion.
Thank you so much, Lakshmi.
Next panelist is Rekha, dear friend from Bangalore, always smiling, charming, dynamic lady. She is currently practicing in Bangalore from last 30 years and she is secretary of Bangalore OBGYN Society, and she is having many posts in so many organizations. She has organized conferences, presented papers, and she is regularly invited as faculty all over India. Welcome, Rekha.
Thank you, madam.
Young, dynamic Subhash. Subhash, congratulations. Currently, he got elected as a Foxy Endoscopy Committee, and we really need these youngsters in our Foxy. He is working very hard to spread the knowledge, to update our members. He is currently the zonal coordinator to Foxy President, our Alpesh Bhai. He is managing committee member IAG. He is practicing gynecologist and minimal access surgeon based at Calicut, and he is a freelancer at many hospitals in North Kerala. And as you can see, at such a young age, he has got so many awards to his credit. He has got publications and he is invited as faculty to so many conferences all over India. So welcome, Subhash.
Thank you, ma'am. Thank you very much, ma'am, for this opportunity.
Arun is a very, very dedicated person practicing at a small place called as Akola. I think he must be the first one to start such a dedicated laparoscopic endoscopic center there, and he is running a very, very successful IVF center at Akola. He has got clinical fellowship in advanced gynec endoscopy from France. He was past executive member of IAG. He was past president of Akola OBGY Society, and he was organizing secretary of Masterclass 2015. And I must say that he is such a humble person, totally devoted to his patients, to his practice, and with so many limitations, he is providing world-class facilities and world-class treatment to all his patients at Akola. Welcome, Arun, for this panel discussion. I hand over mic to Dr. Kanti Bansal for further proceedings.
Thank you so much, dearest Lakshmi, my very good friend, in fact, my bestie. And it's such a proud privilege for me to introduce her. She's single-handedly organized such a wonderful webinar, especially on such a difficult topic like endometriosis. Let me introduce, because actually she doesn't need any introduction, but still for formality's sake, she's the medical director of Srikhande Fertility Clinic, Nagpur, chairperson designate ICOT 2020, national corresponding editor, Journal of OBGY of India, Jyoti, clinical secretary, national AMWI, past senior vice president, Foxy, founder, patron and president, ISOPAC Vidarbha chapter, received Nagpur Ratan Award at the hands of the Union Minister, Shri Nitinji, and received Bharat Excellence Award for Women's Health, received Nehru Dara Hansotia Best Committee Award, as committee chairperson of HIV AIDS Committee, Foxy, received appreciation letter from Maharashtra government for her work in the field of Save the Girl Child, immediate past president, Menopause Society, Nagpur, past president, Nagpur OBGY Society, visited 96 Foxy societies as invited faculty, delivered 11 orations and 450 guest lectures, publications, 20 national and 11 international papers, and sensitized 2 lakh adolescent boys and girls on do's and don'ts. Very, very proud of you, dear Lakshmi, and I think so many other things she has not written, because we cannot finish all those great things that Lakshmi has done for our Indian people. And she's, in just one line, I want to say that she has a beautiful face and a golden heart. So, both of us have decided today to have a little different panel. And so the panel will have, this is called as a reverse panel, but we have done reverse and also the onward panel. So reverse panel, the panelists will ask questions to the moderator, and in the onward panel, the moderator will ask questions to the panelists. So we can catch the attention of all of our delegates. Otherwise, we have so many panels and so many talks, people are getting fed up, So we have just tried to be a little tricky. All yours, Dr. Lakshmi.
Yes, and friends, we are not having any PowerPoint presentation. So you all will have to be very alert and attentive, and we have tried our level best, and I'm happy that all the panelists agreed for this unique format of the panel discussion. So first I invite Dr. Rekha to ask a question to Dr. Kanti. Dr. Rekha.
Thank you, Dr. Kanti Bansal. It's really a new idea and new project, and I'm happy that both the moderators and the panelists are taken to task.
Yes.
I'll start the first question. Yeah.
You know how good we are. Otherwise, always the panelists are attacked.
Yeah, it's a novel idea, new idea. Thanks for that, and thanks for involving everybody so actively, moderators and the panelists. My first question to you, what is the line of treatment for endometriosis patients who are not desirous of pregnancy?
I
Those
think
who don't want
in this world. I am a fertility expert, you are a fertility expert, and you are putting and this is a endometriosis reproductive webinar, and you are asking me a ulta question. I will try to answer. Yeah. So once you say not desirous of pregnancy, I assume that it doesn't include the adolescent group, right? So if they're not desirous, then let us think about the basics first. So basics, endometriosis is a progressive disease, and endometriosis has no cure, right? So, and what are the impacts of endometriosis? Two. One is pain and one is infertility. So now we have cancelled infertility, only the pain.
Yes.
So we have to also understand that because it is a progressive disease, we have to give our patients something which will be effective. At the same time, it will not have side effects, and patient has to be comfortable taking those medicines. So as far as pain is concerned, we have to really think what could be the safest medicine, the very much proved medicine for these patients. So I think in that we could give Dynogest. Dynogest 2 milligrams. Just now we heard Pratik talking, and he said that we can give 60 months, and I totally agree. I have read this literature which the Japanese have really done it so scientifically, and so we could give them Dynogest first, and later on we can switch to something else. So if the patient is already had children and all that, then we can give them depot, progesterone, intrauterine progesterone. Okay. Some people in the rural area, I think Dr. Arun will agree to me, Arun and I think even both the Aruns will agree to me, that even women prefer to take the progesterone depot injections. So based on the patient's patient likings, we can give them various conservative line of treatment. But supposing they have a very big endometrioma, or the pain is not subsiding with these medications, then we have to go in for a surgical method. But before we go to the surgical method, it's important, that's why, to do a proper diagnosis. Only after doing a proper diagnosis can we proceed to what method of treatment.
Yes.
Correct.
So
if it is
yes.
Yeah, if it is endometriosis, and I'm just repeating what she's saying. If it is an endometriosis and patient is not inclined towards fertility, the medical line of treatment will take the front line. If it is an ovarian endometrioma, that to a huge endometrioma, probably we think that is the cause of pain. I think surgically it should be tackled before the medical line of treatment. Exactly. Isn't it, madam?
So thank you, Rekha and Kanti, for this first question. Now, Dr. Arun Barua, it is your turn to ask question to Dr. Kanti. Dr. Arun Barua.
My first question to you is, Kanti, you have given a prescribed a drug to a lady who is not desirous of pregnancy. People always want to have certain changes in their dietary habits. सर दवा कितना खाएंगे, ऐसा कोई चीज बोलिए जिसमें हम लोग खाना खाते रहेंगे तब हमारा बीमारी नहीं रहेगा. So do you have anything in our kitty to promote this?
Yes, definitely. I think there are a lot of studies these days to say that a little bit change in the diet could really help these cases of endometriosis. The main thing in any of these chronic diseases is that patient should always have a proper nutritious diet, okay, which includes healthy vegetables, etc. But on the contrary, they also say that if there's too much of fruits are given, too much of fruits, that is also not good in endometriosis. Then the patients, the people who are eating fish and the seafood, it's seen, especially Japanese and those people eating a lot of fish, there the endometriosis is much low compared to other areas where these omega fatty acids are not taken into consideration. Initially, people were not agreeing on these diet changes, but definitely now there are studies to say that we should have a proper diet which will decrease the endometriosis. And also, these days, there's a big, there's a big knowledge about why this endometriosis is immunomodulated disease, and a lot depends upon the immune system of the body. And so, to increase the immunity, the antioxidants, etc., we give regularly. This PCOS and endometriosis, both of them together, they have this characteristics of having a problem with the immune system of the body.
Arun, you want to add something to your question, or you are happy with Dr. Kanti's answer?
Definitely, I cannot have questions to Kanti. She is so authoritative and so learned. But my observation over last 35 years is that a lot of patients of endometriosis are being treated by Ayurveda and by our allied branches. And yes, other than us, they also get huge success by making some alterations in a diet. So that becomes a big question to me. What type of diet do they really prescribe for only success through diet? That was my only question of asking them. And if you look at a diet protocol, it is pure veg diet, low protein, low carb, and no fat. I don't know, the success rate would be around 20 to 30% based only with diet in those cases, but that is becoming a more question mark to me because there is no evidence-based recommendation of diet as a treatment protocol for endometriosis till date.
Arun, as far as you said about the Ayurvedic treatment, whenever any of my patient comes and talks about Ayurveda, I always tell them, see, I do pure allopathy. I do not know about Ayurveda. But in our scientific, literature and whatever is given of diet, that's what I have just now told. And I tell my patients, please don't mix up Ayurveda with allopathy. But some holistic treatment is there. I've seen a patient with severe endometriosis. They want to die. For such people, holistic treatment, what even Sunita told, I believe in, truly. I have saved one of my friends suffering from COVID. I sent her all the mantras and she had the COVID in her, one of my centers in Madhya Pradesh. She had in her brain. It was so sad. Everybody thought she's going away. But then I sent her all the mantras and she became all right. That I am not such a big believer like Sunita, but then COVID has made us to believe in all this. So I tell them not to mix up Ayurveda and allopathy because we do not know much. But holistic treatment like, acupressure, acupuncture people are using. And I also tell my patients to do meditation, yoga. That really helps.
Yeah. So thank you for bringing out and discussing the holistic issue in the management of endometriosis. Now it is my turn to ask question to another Arun, that is Arun Rathi. Arun, are you ready?
Yes, ma'am. Good evening to you all.
Good evening, Arun. She is a 28-year-old dancer, married for 5 years, suffering from primary infertility, having bilateral endometrioma. Right side is 6 centimeter and left side is 4 centimeter. I know you do both endoscopy and ART, so you are the best person to discuss this case management.
Yes, I mean, this particular lady, she has bilateral endometrioma. So the disease stage is grade 3 or grade 4. I don't know the report about involvement of rectovaginal septum. But does she has any clinical symptoms of, dyspareunia?
No, severe dyspareunia. There is no male factor. And she has come to you with only ultrasound report. Now, how will you proceed?
Yeah. If she doesn't have symptoms of agonizing pain and it's only infertility, then a transvaginal sonography to map the ovary would be a vital thing. If I am able to see a good antral follicle count, and if the endometrioma is peripheral and she has not received any treatment, then I would like to try the medical management first for this lady. The male factor is normal, the cycles are regular, there's no dysmenorrhea. Then she's a young lady, 26-year-old. Then, and as she's a dancer, she is physically fit and active as well. That gives me a stronger counseling opportunity also, because these are the patients who are usually receptive, professional and hardworking. So that makes another positive thing to treat these patients. So I would put them on conventional treatment for 3 cycles of ovulation monitoring and planned relation. If she doesn't become pregnant in a documented ovulatory cycles, then here is the time I would discuss the other option as doing an HSG and then putting them an IUI, because she does not have clinically agonizing disease. So documenting tubal patency and then encouraging her for an IUI for another 3 cycles. If she becomes pregnant, well and good. Of course, the chances of pregnancy I would realistically discuss with her as around say 25% in 3 to 6 cycles. If she doesn't become pregnant, then here is the time that I would like to intervene by operative intervention. Here, documenting AMH would be of a prime importance to me. If the AMH is reasonably good, more than 3, then bargaining this kind of time is justifiable. But if the AMH is less than, let's say 1.5 or 1, then I would be aggressive in getting into an aggressive operative management. Young patient, if I put in a scope and if there is an alteration in the tubo-ovarian relationship, the pelvic anatomy, then correction to a near normal anatomy would be a vital. If AMH is good, then doing a cyst wall enucleation and trying to achieve the complete cytoreduction would be my aim. And if anatomy is achieved properly, cycles are regular, removing the disease as much as possible to the tune of 98-99% would definitely put this lady into a good prospect of achieving pregnancy even naturally, because I do give an opportunity. Once a surgical correction is done well, then I leave them for natural conception, because coming to the hospital does add to an agony or stress to the couple. 3 cycles of planned relation between day 10 to day 16. If they don't achieve pregnancy, then giving them a choice of either planned relation, IUI, and then if they don't become pregnant, only then IVF. That would be the last resort to advise to this couple.
Thank you, Arun, for sharing your thought process. Now this question is open to all the panelists. Do you want to add something to what Dr. Arun Rathi has answered? Subhash, you want to say something? Yeah.
No, I will agree to sir's principles in terms of the surgical aspect, ma'am. Definitely yes. Now regarding to the infertility aspect, all I can suggest is what Dr. Pradeep sir had also said is, once you have operated in any case, not only this case, any case for an infertility case, now please do not put them on post-operative hormonal therapy. That is something which we commonly see. More often than not, we see this. Patients are always put on OC pills or some sort of generous agonist. Now, this is the best time for them to conceive. Once you've altered the tuber axis, if you've taken care of the cyst and everything, you've done all the idiocylase part of it. Please do not put them on a hormonal therapy unless and until you are actually planning for an IVF, where you can say the male factor is very bad, the tubes are totally damaged, the ovarian reserve is very, very bad. Yes, in those aspects, if you're planning in terms of an IVF, yes, there is a role for GnRH, maybe for a down regulation or something. But otherwise, if it's a stage 1 or stage 2, all I can advise to everybody, all the people here is that please do not put them on any hormonal therapy for infertility. If it is of pain, yes.
Point well taken, Subhash. Paresh, you want to add something? Paresh, you want to say something?
No, I would like to agree with Arun sir, because in my opinion, post-operative GnRH therapy is important to avoid recurrences for this kind of a patient. Rather than buying time, we are actually giving GnRH for preventing recurrences. So the basic purpose is different. What Dr. Subhash has told is absolutely correct. If you want to buy a time for an IVF, that's a good option. But for me, giving a GnRH agonist is just to avoid the recurrences, because recurrences cost a lot for us.
Arun Barua, you want to add something?
Basically, what I would do is a good counseling session explaining A to Z of the knowledge that we have of endometriosis up to date. Then it is always better to give them a choice. If you want, you can take a second opinion, because your status has to be perfectly clean in front of the patients. But all said and done, all points of my dear friends are well taken, and whatever is best in that particular scenario, because scenario will depend upon the feasibility of that area. It is not always possible to have the best possible care in all places across the country. So we'll have to respect their treatment protocol as well. Thank you.
Rita, you want to say something? Unmute yourself. Rita, unmute.
Yeah, sorry. Though she's 26-year-old and we consider relatively young, since she's a case of diagnosed endometriosis, I will not give her the chance of having a planned intercourse post-surgery. I will hasten her fertility part post-surgery at least. I'll advise her IUI. If she does not agree, then on last resort would be the planned intercourse in this case. Immediately, I'll tell her to hasten her fertility and get pregnant.
No, definitely. Superovulation is definitely yes in these cases. Stage 1, 2,
Yeah.
definitely yes.
No, that's what I'm saying. I'll not agree for
IUI,
planned
yes.
intercourse. I'll tell her to go for superovulation.
I will go with Arun Barua that we have to counsel and we have to individualize depending on her social, financial and her customs and what is the couple preference. So you have to counsel and let them decide. But what Arun Rathi said is evidence based. So we are here to agree to disagree. So now let us go on to our reverse panel again. And I invite Dr. Arun Rathi to ask a question to Dr. Kanti Bansal. Arun, your turn.
Yes, ma'am. Ma'am, since the gold standard of diagnosis of endometriosis is actually endoscopy, laparoscopy, but it's not always feasible. It's an invasive procedure. We are looking at the markers. CA125 is commonly used, but it is a poor marker having a poor sensitivity and specificity. So there is a lot of literature or talk about interleukins 2, 6, 8 and its presence in the peritoneal fluid. So please elaborate on that and how much is the sensitivity and specificity of interleukins in terms of endometriosis, diagnosis of endometriosis.
Yeah, so very good question, because diagnosis is most important, and it's not only the management of endometriosis but diagnosis also is totally unclear to most of us. So what I feel that is peritoneal endometriosis, especially the implants, they are not seen on sonography. On sonography, we can only see the endometriomas. So endometriomas are relatively easier to diagnose. So now there is a need for diagnosing these endometrial implants. And so what can we do? CA125 is a marker, no doubt, for endometriosis, but we only know the prognosis. We can't say that, okay, if CA125 is raised, then this patient is having endometriosis. So now IL-6 is currently studied a lot, and it is really used now for diagnosis, and this is used in early diagnosis. So which is very beneficial. Otherwise, generally we diagnose endometriosis at a very late stage and it's beyond our capacity to treat this patient. So we could include IL-6 in the early diagnosis and detection of endometriosis.
Arun? Yeah.
Yes. Arun,
Madam, yeah, I would like to know that how is this peritoneal fluid has been taken for studies? And there are a lot of papers available. So is it by the endoscopic route or by the transvaginal USG guided aspiration?
USG guided would be better according to me because it's minimally invasive. But both the methods can be done, both laparoscopically and the transvaginal through the a posterior pouch, especially that could be more easily done.
Okay, thank you.
So good discussion on the interleukin part. Now I invite Dr. Paresh Gandecha to ask a question to Dr. Kanti Bansal.
Good evening, madam. Madam, we all know that there is a immunology as one of the causative factor for development of endometriosis. So we all are aware about immunological theory for causing endometriosis as an infertility problem. Can you please highlight some immune enhancement treatment modalities for treating endometriosis cases?
Yeah, so first of all, we have to understand the basics in endometriosis. What happens is there's a lot of inflammation, and so we have to deal with this inflammation and also the immunity problem. So inflammation, we are giving many of the anti-inflammatory drugs, and along with the anti-inflammatory drugs, we should combine with the antioxidants. Those could be tried. A lot of antioxidants of different compositions are given for these patients, and they really do work well, including multivitamins, carnitine, L-arginine. All these are given in our endometriosis patients. In fact, every endometriosis comes, and from day one, I start with the antioxidants for them. I somehow believe that this is correct. This theory of immune system being attacked by this so much of inflammation is correct, and that will definitely help these patients. Yeah,
Paresh, you want to add? Then I can see Arun Rathi wanted to say something.
Madam, there is one regarding anti-inflammatory treatment for these kind of endometriosis patients. Anti-inflammatory normally causes anovulation or failure to get ovulation properly and causes retention of follicles. So do you have like to advise some specific days of menstrual cycle when she should not take anti-inflammatory treatment?
I don't think so. Anti-inflammatory drugs, as far as I know, maybe somebody can highlight this, would not suppress the ovulation.
It causes a retention of follicle because prostaglandins are required for follicular rupture.
So you could give just in the early proliferative phase or in the menstrual phase you start and continue to give in the early proliferative phase. That's what comes to my mind.
Thank you.
You want to say something, Arun?
No, ma'am. No.
Okay. So now it's my turn, and this question is for Subhash and Rekha. She is 42-year-old. She has completed her family. On transvaginal scan, there is a 6 centimeter endometrioma that is unilateral on left side, and her main complaint is pain. She has come to you that she wants relief from this pain. So I want Dr. Subhash to speak on the surgical part and Rekha to cover the medical part. Subhash first.
Yes, ma'am. Ma'am, regarding this lady, ma'am, who is 42-year-old with completed family and endometrium of about 6 centimeters. Now, she says she has to be relieved of pain, which means that she has tried all the medical area of treatment. For sure, she has tried the analgesic, she has tried the hormonal treatment, and still she is not responding to this particular treatment. Now, that is when I personally would like that, since she is 42-year-old and she says that the pain is intractable. Again, so when this condition, I will definitely like to go ahead and do a surgical line of treatment here, under the presumption that she's had all sorts of medical line of treatment and she's not responded to that. Now, in this, my approach to this cases will be to remove the ablation of the endometriotic implants, if at all I have. Along with that, I would like to do the cystectomy part of it. Definitely, I would like to remove all the cystectomy part of it because I do not want recurrence. She's actually somebody who is completed the family, if I'm not wrong. Yes, she's completed the family. So, cystectomy part is a definitely yes, but I'm not sure how the seniors will agree to me if I say that I will go for no for it to be part of it. So just removal of the. I'm not sure. I may be crucified for saying that, but then since it is
Not at all, Subhash.
Because Arun Rathi is there, Paresh Gandecha is there. So
I would go with you for oophorectomy because she's already completed a family.
Yes, completed family. The main reason for this is.
But she's a 42-year-old.
I do agree, ma'am. I do agree.
The other ovary is normal, ma'am,
Yes,
and
ma'am.
one ovary is more than enough to have estrogen to maintain for the next 10 years.
I do understand there are a lot of controversy because cystectomy was oophorectomy. Yes, I accept and I respect all these sentiments, but then I think looking at the larger perspective of the patient, the patient has had enough of pain. Under the presumption that the other ovary is normal and there are not much of additions or everything, I think oophorectomy is a good option. Of course, coming back to the cystectomy part of it, definitely yes, we'll do the cystectomy part of it, taking care that you remove all of the capsule and all the cyst part of it. You do the adhesiolysis part of it. Merely doing a cystectomy alone will not give her a relief of pain. If there are adhesions, if the uterus is retroverted, if it is fixed, if the sigmoid is added, if you do an adhesiolysis, definitely yes, that is going to help her a big part in relieving her pain. Of course, as Arun sir told in the first case, though it was a primary infertility, 26-year-old lady, always look out for the chance of having a deep infiltrating endometriosis. Now, if you have a deep infiltrating endometriosis and you have not done justice, and by removal of that, now this patient will definitely have still pain. So I think we may not have done justice to it. And Rekha madam will pounce on me saying that I've done an incomplete surgery and so medical line is better for this case. So definitely yes.
No. You will be surprised to see that I will be supporting you because I always think medical line of treatment is second option in this case. Dr. Arun has come as your savior in saved you from getting crucified here.
The point was that
I will.
Subhash, my another lead is would you combine hysterectomy?
Sir, oophorectomy itself I am told with lot of fear.
No, but it's your patient, 42-year-old,
yes,
intractable pain. Now,
definitely,
like
sir.
as a clinician,
definitely, sir. From the bottom of my heart, if this patient is having so much of pain, hysterectomy definitely would be option. Now again, for the oophorectomy part of it, I've seen. It is sad to say this, but I've seen a lot of people, doing surgery for endometriosis. They do the hysterectomy for this, and they leave behind they leave behind the ovaries, which are diseased ovaries. I think that is a crime which you're doing to this lady now. Now, if you're doing for an endometriosis, and both the ovaries are added. In this case, when she's completed a family and she says that yes, I have to relieve the pain, hysterectomy alone, hysterectomy with bilateral saphenophractomy is definitely advisable. But under the present, please tell the patient that even if you do a hysterectomy with bilateral saphenophractomy, the pain relief is not going to be 100%. She may have some amount of deep infiltrated endometriosis which can cause some pain. Always say this, because do not be under the give her false hope saying that I will do hysterectomy, everything of yours will be relieved. No, be very practical, be very truthful to the patient to say that yes, you may have some amount of retained. I will do my level best in removal of that. And if I am not confident of doing this, I can rather send the patient to somebody who is an expert in doing this. There is no shame in this.
Subhash, I will go with you because I have really so many grateful patients whom I did hysterectomy with bilateral oophorectomy with adhesiolysis and as much clearance as possible. Then only you can tell her that she will have substantial pain relief. Of course, I will also not take guarantee, but the pain relief is
very true, ma'am. Very true.
And if you give post-op, if you suspect that there is some spots left behind, give her post-op GnRH analog, counsel her well, and their really quality of life improves a lot. So
now,
anyone who
differs. If I can add one more point to what Madam said, all the panelists sitting here are very, very senior to me. But still, whatever little experience that I've had in the last 10 to 12 years, I've seen it. Even if I leave behind a little bit of endometriosis in the case of, in hysterectomy, if I leave behind a little bit of endometriosis, which I'm not able to, still the patient doesn't have that much of pain. Even if you leave, I'm not saying advocating for leaving behind a little bit of endometriosis, but if in spite of your best efforts, if small amount of endometriosis is still left behind, still the patient is relieved very much. And as you rightly said, patient is very grateful to you, madam. Patient is really, really grateful to you. But again, the audience, please do not take the wrong impression that we are here saying that hysterectomy is the panacea for all the. No, we are not saying this. Definitely, we are not saying this. This particular patient. Madam,
I want to congratulate you for being so assertive. And you said that so many seniors, according to me, after 5 years of our practice, all are equal, no senior, junior, as far as our knowledge is concerned. I really agree. Another point I want to add to yours for supporting hysterectomy is that many of these endometrioma patients also have adenomyosis.
Yes.
And sometimes
Very
adenomyosis,
true.
Yes.
so you have to, do properly. Whatever you do, you marry properly. You whatever you do properly. Surgery also you do properly. Yeah.
One more last controversial point that I would like to say is, if you are doing a surgery for endometriosis, the only thing you can give assurance to that patient in an infertile patient is recurrence of the cyst. The
That
only
is
thing you can reassure her is not.
But here she's 42-year-old and in front of all the endoscopic surgeons, I would like to comment, rather I would dare to say that not every gynecologist is a level 3 endoscopic surgeon, because endometriosis surgery requires a lot of talent. So don't shy away from offering laparotomy, but do a complete surgery for that lady.
Absolutely agree with you. Absolutely agree with you.
You are comfortable with cyst aspiration, you will just put, at least this case, just do cyst aspiration and give her post-op GnRH analog. No. It's a crime which you have committed. Don't have the endoscopy facilities, not confident of doing endoscopically, do laparotomy and do a complete surgery. This is the another take-home message which I want.
Justice to the patient. Justice to the patient is very important. Whether we do laparotomy, whether we do laparoscopy is not a issue, as you rightly said. Arun sir, you disagreed with something? Arun sir, you disagreed with something?
I know, that is what I said.
I'm not disagreeing.
डरपोक लोगों को बनना ही नहीं चाहिए एंडोस्कोपिस्ट always to be bold and take proper decisions.
But endometriosis requires lot of skill. There is a steep learning curve, and it is better that instead of doing bladder bowel and ureteric complications, do laparotomy. I mean, my take-home message is that if you are not comfortable as a surgeon, if you are not confident as a surgeon, please go ahead, do laparotomy, but do a complete surgery and try to avoid complications as far as possible for this lady. Yes, Arun.
Experts here who do real experts of the world are sitting just next to my hospital. I send them Sanjay Patel, Deepak Limbachia, so many. Why do you want to catch hold of the patient? They will come back to you to a proper person.
No, tell them these are the centers who can do a wonderful job for you by doing a endoscopic surgery. Yes, of course. You should tell your patient that this is not with you. If she wants to go away to the best center of excellence, why not? Let her go.
Yeah, I mean, absolutely. But just to have an input from the esteemed experienced panelists, in a case of endometriosis, what is the incidence of scar endometriosis, or rather cyclical pain?
Arun, ruk ja.
Sorry.
Let Rekha finish. That's what Dr. Lakshmi Madam is saying.
Also, everyone agrees that hysterectomy with bilateral oophorectomy, endoscopy first option. But if you are practicing in a rural setup where there is no center of excellence for doing endoscopic surgery, and she is not willing to travel outside, don't hesitate to do laparotomy. So I have modified Arun.
Dr. Lakshmi
both Arun are in periphery and they are pro endoscopy.
You are an exception. That is what I told in your CV only. But not every periphery is having a surgeon like you, na, Arun.
No. Everybody is excellent. I mean, we are.
That requires lot of setup also, Arun. I mean, it is not only surgeon. It is a combination of all the things: your gadgets, your experience, your setup. But yes, why not? Keyhole surgery is the today and tomorrow. I mean, it is the future.
We did not mention about the vaginal part of it, vaginal hysterectomy. Why
I
not
was
vaginal?
about to tell, seeing Arun Rathi sir, I was about to tell, कि vaginal NDVH का भी sir तो is an expert in NDVH also.
Dr. Lakshmi Madam asked only about cystectomy. Dr. Arun stirred the hornet's nest by asking hysterectomy. Now he is going for NDVH and scar endometriosis.
No, madam. We do see lot of patients with laparotomy. Even with cesarean, lot of scar endometriosis is seen.
Correct.
Scar endometriosis and cystectomy versus fulguration. You are not supposed to touch these two topics, Arun Barua, huh?
No, actually, I just add something that we have just left behind. We had just discussed something about immunotherapy, and I'm throwing a big basket open to all of you. I have used this immunotherapy, natural immunoglobulin, with the brand name called Varglov over last 35 years. And I can assure you that your pregnancy rate with endometriosis will increase by nothing less than 20%. That is my vouch for that particular medicine. So we need to do an end-to-end research on this molecule. And I'm sure immunology and endometriosis and enhancement of the with immunotherapy will go a long way in medically treatment of endometriosis.
Sir, kindly elaborate your experience. How do you give in last 35 years?
My dose is I use 16.5% Varglov injection, which contains natural immunoglobulin every 21 days, and I continue it even after pregnancy till she delivers.
Is it to be given intramuscular or IV?
Intramuscular.
Intramuscularly.
Actually, we have used lot of this injection bundle.
As we use in RIF patients.
But we use it for repeated miscarriages, So
Basically, they are for enhancement of the immunotherapy in general. They are not specific to one particular disease process. So, taking them from that part only and incorporating in your medical line of treatment of endometriosis will be really beneficial to your patients. It's an eye-opener maybe for all of you.
Okay,
Sir, do you
suggest that you should compile and publish this, because it's very important.
Yes.
Among our Indian patients, if you've done such a good work, it would be really worthwhile to publish it. Then all of us are going to follow it.
Sir, do you take any help of any investigation before you start? Like all patients of endometriosis or grade 3, grade 4 only who have not become pregnant, or
grade 3 and grade 4 based on our laparoscopic data.
Okay. And any investigation you take help to to categorize them?
Nothing. We basically make a note of the clinical improvement and the improvement in fertility.
Okay.
Clinical
Thank you so much, sir, for your input.
Clinical improvement of the pain and dyspareunia part, and the enhancement of the fertility outcome.
Shall I talk about the medical management now?
Yes,
if the floor permits me.
Suppose this patient is not willing or is a high risk for surgery. Now comes the role of medical management. Or she wants to find time that madam Diwali hai, bachcho ka exam hai. So you pitch in how to manage this lady.
Yeah, of course, I very much agree with Dr. Subhash Malya that as Dr. Lakshmi Madam has told, except for these exceptions, she is the candidate for cystectomy because it's a 6 centimeter unilateral, and pain also will come down and recurrence also will come down if she undergoes the surgery, all of us know. But coming to the medical management, other than what Lakshmi Madam told, suppose it is a case of recurrence, like she has undergone the surgery and after that the problem has come back, then that is one more indication for medical line of management. Under that, I will consider first is now again we don't have the question of the reproductive part, so we are in a better situation now. We can she's completed her family. This is the role again of the medical management. Medical management takes a stronger hold here, and first would be, as Dr. Pratik Tambe told, the Dynogest, and that's a continuous treatment of 2 milligram OD is that will definitely reduce her pain, and her other symptoms also will come down. It is as effective as the GnRH analog, and it has taken the first seat now, and as it is a well tolerated compared to other drugs like GnRH analog or danazol, and there are no side effects like androgenic side effects or the bone mass loss unlike GnRH analog, and well tolerated even if it is used for many months together. Some people have continuously used for an year also. The second would be according to me, would be the LNG IUC IUCD. As she is 42-year-old, she might not have taken some precautions regarding the contraception, might not have undergone tubectomy, though she has completed her family. I would advise the LNG IUCD because that will take part of endometrioma as well as the contraception. It will reduce her pain, not only the dull ache, it will reduce her dysmenorrhea, if at all she has, and the size of the cyst also will not increase. The third option with me would be the GnRH agonist, because I can't give it for a very long time, months together, as Dr. Pratik told, and also she's in the perimenopausal age group and her symptoms of hot flush or amenorrhea and those kind of hypoestrogenic symptoms will increase with GnRH analog. Also her bone loss will be much more. So these are the three options I would give her under medical management. Though there are many other like continuous progesterone, OCP or dianazole, and latest Dr. Arun told about the immunotherapy, stem cell, so many other latest things. So summarize, first would be in her case the surgical management and then would be medical management. If she opts for medical management, I will tell her other than counseling, the another counseling would be that she has to monitor herself by ultrasound guidance. In the sense, the size of the cyst should not increase, and if the pain has increased, she has to come back. Though the malignancy is a rare thing in most of the endometriosis, but monitoring is very much important. And as Lakshmi Madam said, medical management would be second, and probably even the under surgical, the aspiration I would put it as last. Medical management only if she is not agreeing for the surgery or she has a contraindication for surgery. This would be.
Kanti madam.
Yes, Squash, you want to add?
I just have a doubt, ma'am. We have just seen a few articles, ma'am, where they say for recurrence and patients like this, ma'am, where you just drain the cyst transvaginal and inject the sclerosing agent. I'm not advocating these things, ma'am, but I'm just asking, what is your take on this, ma'am?
Yeah, I was just hoping that till now no controversies were there. I was just hoping that this vaginal aspiration is not. Some people who are really good at aspiration, who know how to really do it, like most of us, the IVF specialists, many times we are going, without our knowledge, we don't want to go, but we poke those endometriotic cysts, and we know what to do later on, to change everything, all that. But yes, there are many people who have reported regarding good, success rates with, removing by transvaginal. But with caution, if you are very sure that there won't be infection, you cannot be, right? So why to do that? Now, I support the laparoscopic surgeons in this. Don't do anything which is not foolproof.
Kanti, Pratik has put a comment that sclerosing agents are not recommended by ISHRE guidelines. So, I think everyone will agree with you fully that why to go for these controversial things which are not endorsed by the guidelines.
True. No, I just wanted to bring in that point, ma'am. That is the only reason, ma'am.
Answer to your question. So, anybody wants to add anything, or we can move on to the next question? Yes, Paresh, you can ask next question to Dr. Kanti.
Madam, my next question is there any role of doing AMH for all endometriosis cases, whether you are planning to treat it by surgery or medical line of treatment, whether she is actually anxious for getting pregnant?
Yeah, I think we should do, first of all, AFC is important, and also AMH is important in all the patients of endometriosis as far as we fertility experts are concerned, because that saves us, what is the AMH, and then we can explain to the patient, etc. And especially to those patients who have endometrioma and then who have been taken for a surgical management, we need to definitely do pre-operatively and post-operatively, because Paresh, I'll tell you, immediately after the first month of the laparoscopic removal of these endometriomas, there's a dip in the AMH level, and also it depends on which surgeon has done. Really, I'll tell you. So, as Dr. Lakshmi already so much she emphasized that the surgeon has to be an expert. I'm sure all of you here, laparoscopic surgeons, are experts. That's why we have you here. And so only people like you should be operating, not other people who don't know, very junior people have just started to operate and all, because for us fertility specialist, every follicle, every oocyte means a lot. We can give even with 2 follicles. One of my patient, endometriosis, she had only 1 follicle, and I had told her, let's go for oocyte donation, but she said, no ma'am, I want my own oocyte. She conceived. So it is very vital to really take care of the AMH. That was your question.
Yeah, I would like to add to Dr. Kanti's thing. In this era of evidence-based medicine, it is better to document her pre-op AMH, because you never know, she might belong to a low ovarian reserve category, and unnecessarily the blame will come to your surgery. So always document pre-operative, and then only touch the ovary in these cases of where fertility is an issue. Yes, Arun Ratti. Arun wanted to say something. I saw you wanted to add. No.
So a lot of litigations, and all the people are now against doctors so much. So we better be careful. Why should we give
document? Because sometimes with big endometriomas, your AFC measurements are not accurate. You can't see all the follicles on day 2 or day 3, and we all don't have the 3D thing with us. So it is better to combine AFC, AMH preoperatively, counsel her properly, take in writing whatever you have counseled, and then go ahead with your surgical part. So next question, I invite Subhash. Next question is in continuity with this discussion only. You can ask to Dr. Kanti.
Yeah. Kanti madam, my question to you is regarding ovarian cystectomy versus just the cyst wall fulguration. What is your take on that, ma'am?
Yes. ART consultants here.
Anyway, I like this because
more so in an infertile case, ma'am. In an infertile case, ma'am.
So actually the law is that we should be doing a ovarian cystectomy and not fulguration. But there are some exceptions, I tell you. Supposing the endometrioma is so small, you have done big endometrioma on one side, there is a small little endometrioma on the other side. You would like to leave that, right? As experts, you all want to remove that one also. So in that, you may not be able to do a cystectomy, and then that is the indication where you could do fulguration very carefully, not seeing that the other part of the good part of the ovary is not destroyed. So that is one indication. Otherwise, in all other cases, we have to do a cystectomy. By doing the cystectomy, what are the benefits? We are not destroying the part of ovary which will give into the follicles. The AMH is not going to go down. So it's better to do a cystectomy. And if you see a cystectomy done on a laparoscopy, it is so easy. It's coming out. But believe me, it's not so easy at all. So
until you get the proper plane.
Told experts for surgery.
But in spite of all this, ma'am, people, infertility specialists always, they scold us that we destroy the ovary, we remove a lot of ovarian part. So basically, I always say that always counsel the patient. If you're asking for a surgery, always counsel the patient that there is a chance of decreased AMH. Tell the patient initially. I'm sure Ritu madam, Lakshmi madam, Kanti madam, Parit sir, all will agree with me regarding this, that always counsel the patient that you're going to lose some amount of your ovarian function and your loss of AMH also because of the surgical aspect of it. That's Kanti madam, please.
I want to tell you one thing. I have realized, what does a good infertility management consist of? It has 3 pillars. 3, not 1. It's not only ART. It is ART, it is sonography, and it is endoscopy. So all your pillars have to be strong. Then your building will be, will shine. Otherwise, one pillar is weak, you're gone. So we have to have a teamwork. We cannot scold the endoscopist cannot scold the ART, blame each other. Then who will be the sufferer? Our patients. You don't want to do that.
Subhash, you will get more scoldings if you fulgurate than do cystectomy from ART specialists.
No, definitely, ma'am. Definitely. Now, again, as Pratik sir said, in X-ray guidelines, If we have less than 3 centimeters, there is a rule for fulguration, but otherwise, if it's more than 3 centimeters, straight away go for cystectomy for an ART procedure. Again, always do, as I keep saying, for a medical legal purpose, always document. Now, I'm not sure whether we should do an AMH for all patients before surgery, but it's always advisable. It is always advisable for our own safety. I think in the era of ART.
Related to the endoscopic expenses, AMH expenses is nothing, and then the lab people will also give you, if you have friendly relation with them, they'll give concession for to some patients for not able to, afford that.
And many of the patients nowadays are 30 plus age and would have gone to many other places, window shopping, and then come to us. By then their AMH would invariably be low.
Arun Baru wanted to add something. Everyone can pitch in.
Yeah.
Yes. Yes.
But what I'd like to add here is doing an AMH immediately post-op is not indicated. You should wait for at least 3 months to get a proper judgment of the surgery, if at all we want to use it as a module measuring our skill of an endoscopic surgeon. That's number one. And within 6 months, 90% of these patients do come back with a normal AMH. So AMH per se cannot really predict the skill of an endoscopic surgeon in managing endometriosis.
That is what I said.
Number two,
AMH should be documented, Arun.
Yes.
Then only you can compare with.
I'll clear your point, Dr. Arun. You are saying correctly. Actually, the problem is endometriosis is such a disease that affects the ovaries and the AMH. And also the surgery will add fuel to the fire, so we have to be careful. And I'm not saying that immediately after 1 month, whatever the result we get is correct. But generally we see that after 1 month, if you do, there will be a reduction in AMH. But what you said was right. After 3 months, we should, really
another important area that we all endoscopic surgeons must have assessed is ovarian tissue preservation in grade 3 and grade 4 endometriosis. I think that should be in our armamentarium because that is going to be a very important protocol in generation next.
And so to sum up the, can I sum up about infertility treatment, Dr. Lakshmi? So, according to me, I'm talking about ART. So stage 1 and 2, it's better to do IUI, and it's seen that if you do controlled ovarian hyperstimulation with IUI, the results are very good for endometriosis, as higher, much more higher than those when we do for unexplained infertility. And for grade 3 and grade 4 endometriosis, believe me, it's not surgery, the ART, that's the best. ICSI especially, and in fact I had presented one paper at Siena in the endometriosis conference in France. So even in that I had studied that the oocyte donors and those who can't give their own eggs, it happens for many of the endometriosis patients. The results are very good with ART. So we should, tell them to opt for ART sooner, because for all infertile patients, age also matters equally as much as the disease per se.
So let us move to the last case of today's panel discussion, and this case is for Paresh and Arun Barua. She is a 28-year Para 1, LSCS was done 1 year back. Now she has come to you for severe cyclical pain every month at the scar site. And there is a 4 centimeter partially mobile non-tender mass at scar site. So management by Paresh and contraception by Arun Barua for this case.
Looking at the history where it's clear-cut dealing with a scar endometriosis case. And for a 4 centimeter scar endometriosis, it is more like a scar endometrioma. 4 centimeter is a big mass. So I would like to go for a surgical excision followed by GnRH analog for at least 3 months, 3 cycles to prevent recurrences. And that's it for the management. And we'll encourage them to have an early second pregnancy, because then the pregnancy will again suppress endometriosis. So they will have a more number of disease-free years altogether.
Arun Barua? Arun? Unmute.
Yes, what I would like to add is there is no standard line of management for contraception in scar endometriosis. But one thing is sure, to enhance the best outcome in scar endometriosis, you need to perform the surgery during the days of the period so that you define the tissues perfectly and excise them in totality, because that is the best part of the treatment. If you are leaving a small unseen part of the endometrial tissue, there is going to be recurrence for sure. We know that this is a microscopic disease. Microscopy cannot be detect every tissue level endometriosis, but doing that during menstruation will enhance the outcome for sure. And as Paresh rightly said, we can always encourage them to go for a next pregnancy if at all they require. But my source of contraception would be Depo-Provera. Every 3 monthly till they are desirous of a pregnancy, not GnRS.
Yeah, so I have read somewhere that you were absolutely correct, even Paresh, that there's definitely a role of surgery, and that is very wide excision we have to do, so that we don't have, that is one point number one. And the second point was also very important, pregnancy. We asked her to get pregnant soon. The third thing is, supposing the patient doesn't, we have to counsel and all, but sometimes the patients are very adamant. Supposing they don't agree for surgical, or they say we'll get it done after some time, but give us something for the pain. What will you give? Subhash, Paresh, Arun, anybody?
Gabapentin.
Gynecologists will be a first line of treatment if she don't want to go for a surgery.
Correct, exactly. So the newer line of treatment, apart from surgery, and also to prevent the recurrence. Somebody told GnRH agonist. Yeah, GnRH agonist also could be given, but then I heard that for scar endometriosis, just 2 milligrams per day, continuously at least for 6 months, could reduce the pain and the redness. Whatever, it will reduce the scar endometriosis.
Anyone wants to add anything to this?
Yeah, just want to add that whenever you are dealing with scar endometriosis, wide excision, as the word rightly used by madam, but you must send this specimen for histopathology, because you must have a disease-free margin of at least 0.5 to 1 centimeter, so that you are sure that the recurrence goes down. As sir has rightly said, Barua sir, that you must do it during menstrual phase. It's always tender. In the history, you said non-tender, but it is usually tender, this particular mass. And sometimes you need to do such a wide excision that you may use mesh plasty after excision, so that you are able to do a thorough job. Because otherwise, when the defect is big, you are worried that there will be a risk of hernia in these patients. So wide excision, and then use a mesh plasty to take care of the defect.
Anybody wants to add? Then I would like to have the take-home message from all the 5 expert panelists, and then final comment from the authority on endometriosis, that is Dr. Kanti Bansal. So first, this case discussion is still open. Anybody wants to add? Add or agree to disagree, whatever. No, so I would like to have take-home messages starting from Arun Rathi, then Arun Barua.
Endometriosis.
What would you like to tell to the participants, our general OBGYN who are doing endometriosis in their daily practice?
The first thing is, this is a unique webinar where only the participants are actually the consultant. I mean, the people who are participating. One thing is there, but it is a very healthy discussion, very enlightening.
Experiment, you all agreed, and I'm happy that without PPT, I mean, I'm sure the participants also must have been very happy that without PPT we engaged everyone, the moderators and panelists equally.
I'm very happy because all the panelists have been given chance to speak, and they are interacting, each and every one. Otherwise, it becomes very monotonous. They're asking, and we are again and again talking. Even though I am a very talkative person, so I keep on talking. I'm sorry about it, but then Yeah, I like this, reverse. I told Lakshmi you'll really like it. Initially, Lakshmi was
We enjoyed it, madam.
I was reluctant to be very frank when she told me. Yes, Arun. We will start with Arun Rathi, then Arun Barua.
Madam, all the inputs have been fantastic. These are all take-home messages. It's a chronic disease which I have not understood well. It has to have, apart from the medical or the scientific knowledge which we have to take the emotional part of the couple into account when it comes to infertility or the pain part, because the pain sometimes goes almost for 8 to 10 days per month, and that where there is a quality disturbance of quality of life of the mother, the lady, and she is the head of the family. So if she is in pain, the entire family gets disturbed, distracted. So we must have a thorough counseling, and depending upon, because we must ask in the history that does this pain disturb you in your day-to-day life? This is the leading question I always ask, and that gives me a clue how aggressive I should be in taking a surgical decision versus a medical management. Because surgical decision should never be a problem as long as you make the treatment affordable. We work in periphery where we don't think of money. It's the outcome of the patient. So it works well if you are able to take as a lead that if it is disturbing you in your day-to-day life, be aggressive, because surgically if you are able to treat, it gives a long-term pain relief. When you improve the pain score from 10 to 6 or 5 or 4, she is back to normal routine, and that is, and they are very happy with you. Even in the process, they get 5-7 years of pain-free quality of life.
Point well taken. Arun Barua, you are next. Take home message.
My take-home message is regarding counseling, because I always use the digital platform to educate my patients about the consequences. Because today the digital platform should be utilized because they need to understand what sort of treatment they are likely to undergo. Even if this is surgery, then also they should understand what type of surgery they are likely to undergo, so that they have a fair overall idea of the disease process, and there, if they agree, then only we should take the patient for surgery. This is number one. Number two, we should go all out to make an early diagnosis if at all it is possible. By that I mean the adolescent endometriosis must be picked up based on the symptom displayed. That I mean is the painful periods, which many of our educated family they say, oh no, ये तो होता ही है भाई, तुम्हारा पीरियड शुरू हुआ है, ये 2-3 महीना चलेगा, उसका बाद 2-3 साल और शादी के बाद ठीक हो जाएगा. So this particular concept of endometriosis growing within even after having documented symptoms should be discouraged, and we should take more awareness programs to make early diagnosis. I'll give only 2 take-home messages from my side.
I agree with you, Arun. Somehow there is a myth in our Indian culture that this dysmenorrhea will disappear after the marriage or once you have your first child. So what you said is very correct, that as a treating doctor, we should try to diagnose early. So point well taken. Now Rekha, it is your turn. Take home message.
Yeah, Dr. Lakshmi Madam and Dr. Kanti Madam, you did a wonderful job. It's a unique presentation, that too without slides. It was probably difficult to engage all of us. In spite of that, you've done a very good task. We covered surgery, lab, ART, everything almost we have covered in this short span. I was about to tell the same take-home message as the previous previous Dr. Arun told. The thing is, it may be in any age group, endometriosis. It may be in adolescent or even the woman who is around 40, 45, about to complete her family. We should take it very seriously, because we have to heed to her symptoms. We should listen to the symptoms what the patient complains of, especially the worsening dysmenorrhea. it will not be the stagnant kind or the same kind of dysmenorrhea. It will be worsening, and some women may not reveal that it is so incapacitating, and she's especially the working women may be taking holidays, and some may get even to the extent of suicidal tendencies. Also, the other symptoms they may have, like even simple backache when the uterosacrals are involved, or they may have dyspareunia. So these aspects also we have to ask. And coming to the investigation part, the diagnosis oriented investigation only, in the sense it is the early encouraging them for a diagnostic laparoscopy, because certain kind of endometriosis like DIE and those kind which are not space occupying may not be made out by a simple ultrasound and think that ultrasound transvaginal is normal and leave her. This is a diagnosis part. Coming to the treatment part, whether it's a surgical, medical, ultimately the goal should be relief of her symptoms or whatever her demand is, whether it's ART or symptoms like hysterectomy, whatever. But we have to respect her time, money, and energy when she comes to us. This is what I would like to say.
Rekha, and I would like to add that before labeling her as a case of chronic pelvic pain or a case of psychosomatic, there is something wrong with these
exactly.
girls, put in a scope and diagnose, because you never know, she might be a case of endometriosis.
Yes, some small nodules in uterosacrals or something.
Or just labeling her as a case of psychosomatic case. So point well taken. Now Subhash, then Paresh. Subhash, you are with me? Paresh, you can start by that time.
Madam, I would like to summarize the management of endometriosis age-wise. For adolescent endometriosis, if we want to treat them, a primary line of treatment should be a medical line of treatment, more conservative. And for the woman who desires fertility, the line of treatment should be conservative surgery. I mean by that is conserve as much of ovarian tissue as you can, and hysterectomy is no choice at all for a woman wanting to preserve the fertility, and early pregnancy for them as early as possible. Medical management only to prevent recurrences for these cases. And regarding those who have already completed their family, extensive surgery in the form of either oophorectomy or bilateral salpingo, hysterectomy with bilateral salpingo-oophorectomy. As far as scar endometriosis is concerned, Arun sir has already told wide excision followed by medical management as and when required.
Subhash?
I think all of them have actually summed up, ma'am. I have nothing to add except for the fact that Arunda has left. I think I would like to say dhanyavad to Arunda and to start. Yeah, Rekha madam, tumba chennagittu. Thank you very much. Richa madam, bahut acha tha. Bahut धन्यवाद. Ganesh sir, Lakshmi madam, and Arunda, खूप चांगला झालंय. And आभार आहे तुमचं. खूप चांगला झालंय. खूप एकदम छान झालंय. आणि कांती मॅडमला काय तुम्ही खूप आभार.
रुको, अभी जाना नहीं, 5 मिनट, जब तक मैं नहीं बोलूंगी रुको. My take home message is that only you have to, it should be women centric. Whatever Paresh has rightly said, Rekha has also said, whatever she has come to you, if she has come for pain relief, that should be your goal. If she has come to you for infertility, that should be your goal. Whatever, I mean, it has to be patient centric. Yes, Kanti madam, final authority. Give a take-home message.
How many times people have told final authority? Now I'm feeling a little happy.
On endometriosis.
So I'll just tell you all 3 points, which I think are very, very important. First, let us go to the history. In history, we have to ask for congestive dysmenorrhea. I think you all will think, yes, sir, endoscopy ho gaya, wo ho gaya, abhi madam to history pe aa gaye. But it's very, very, very important, because somebody in the panel told me that, you may not get that, spasmodic hai, kuch nahi karna hai. No. To talk about endometriosis to the patient, you have to be very, very patient. Ask them properly, when do you get the dysmenorrhea? You have to really ask properly. Then they'll come out that it is before the menstruation, before the menstruation starts. Now my staff have also learned how to take that history. I don't have to really take so much of trouble. So that is very important. Then when are you going to examine really for these patients? Give the menstrual phase. That is also very important, and especially for to catch these adolescent girls. Many times these adolescent girls will not go to school, bunk the class, and what's the key point? You ask their mothers or father who is close to that girl or boy, that girl, sorry. Ask them, does this girl, after bunking the class, does she play outside or she's in the room catching her tummy and really sleeping? So that will give a clue. So this is about history, whatever right now I'm remembering. Then diagnosis. Yeah, everybody said in the panel diagnosis is not very easy, it's difficult. Until and unless you see one big endometrium on the transvaginal sonography. So for diagnosis, recently there has been one inclusion, very simple. Either you give, and this is for patients who are more than 18 years of age, because the bone development and all that is complete. So give one single dose of GnRH agonist depot, and in the coming menstrual cycle, if she has no pain, then also you can come nearer to the diagnosis. Then there is another study which says that you can even give Dynogest for 1 month, and that congestive dysmenorrhea is not there. Once again, you can diagnose little bit easily. Now, just one more point, when it comes to infertility, most of the times we think of age and all that, but here in endometriosis, any time the patient comes, even at a younger age, we have to remember two things. We have to be aggressive and we have to be active. We have to start the treatment, proceed. We can't just wait, come next month, we'll do one test now. No, this is one condition where we cannot wait. It's an emergency because endometriosis is a progressive disease. Thank you, Lakshmi, and all panelists.
Wait. There are a couple of questions, audience. They want just wait. Be with me for 5 to 10 minutes.
And panelists will now answer.
Answer quickly. I have adolescent patient who has endometriotic cyst of 7 centimeter. How to manage? Just in short, Rekha, if you can take this question. Endometriotic cyst of 7 centimeter in an adolescent girl.
Yeah, I would like to give her first of all the surgical line of management, since it is a 7 centimeter and unilateral. I would like to counseling, AMH and all that. Then when we do the laparoscopy, the diathermy principles we have to take care of, because fertility is so much ahead for her, and the whole chapter she is yet to open. But clear the cyst and then put her on Dynogest and monitor her on ultrasound, other than counseling, and tell her early marriage and rest of the things, get pregnant and so on.
Arun Barua, for you, is Dynogest alone sufficient to prevent pregnancy, and what about the combination of Dynogest plus estrogen? These are two separate questions.
Dynogest alone is enough. There is no evidence across the world to have a combination of Dynogest with estrogen. That's a very clear-cut message to every one of us. Dynogest alone is enough, and it is evidence-based, and it's documented across the world in all the countries where it has been practicing.
Because
there's no need to combine estrogen along with this.
Dynogest does not give the hypoestrogenic symptoms.
Now Pratik is only looking and smiling. So one question for Pratik. Medical management of endometriosis in diabetes. That is the question from audience. Pratik, unmute yourself. Unmute. Medical management.
As far as my knowledge goes, Dynogest does cause impairment of blood sugar levels. It would be worthwhile to have a multidisciplinary team approach and adjust the insulin levels on a day-to-day basis as per whatever dosage you are giving, and ensure that you have good glycemic control.
Good. So thank you so much. We have taken all the audience questions as well. My sincere, heartfelt thanks to dear Kanti Bansal for her innovative idea and for taking the lead in conducting this panel discussion. Dr. Pratik Tambe for beautifully, he really covered all the aspects of medical management in endometriosis, and Pratik, you are going to teach me how to prepare the slides. Huh? They are always mesmerizing. I just look at your slides and the way you deliver your talk.
Always,
So he's going to take a lecture on that.
Pratik's presentations are always unique.
Going to take a talk for us, yeah. And I sincerely thank Ritu and Chandan for chairing the session, and all my esteemed panelists, Arun Barua, Arun Rathi, Paresh Gandecha, Subhash Malia, and Rekha Rajendra Kumar. And I also thank TOG team for providing us the technical support, Bharat Serum for their academic grant, and how can I forget my dear participants who are there with us till the last. So thank you so much. Thank you all once again. See you. Bye.